Hi, everyone. Thank you for joining and for today's Policy Round Series webinar. I'll just give it a few short minutes for folks to join us, and then we'll begin shortly. Okay, so hi, everyone, and welcome to today's Policy Round Series webinar with Jim Kloss, Chief Experience Officer at CareTech Solutions, as well as the National Director at Age Safe Canada and President at Live Easy Incorporation. The Policy Rounds webinar series was created to enhance knowledge translation of aging and technology research through policy-oriented briefing presentations. So each webinar in this series lasts about 30 minutes, beginning with a short introduction that I'll provide, followed by 15 minutes of presentation from our guest speaker, Jim, and a 10-minute question period at the end. So at the very bottom, there's a Q&A box that you can leave your questions in at the very end. The presentations in the series will focus on the policy implications of research findings. Speakers will discuss the challenges that their research aims to address, what their findings are to date, and what all this means for future policy decision making. So as stated before, today we're joined by Jim Kloss, the Chief Experience Officer at CareTech Solutions, as well as the National Director at Age Safe Canada and President at Live Easy. With over 30 years of experience in managing, distributing, educating, and launching innovative products and services within the aging in place and falls prevention space, Jim has been tasked with overseeing the CareFall projects, vendor relations, business operations, and development. Jim provides project management, project leadership, as well as explores the expanding services available through CareFall's vendor partners and any new relationships that will evolve. Jim's relationships with national agencies and healthcare companies provide an opportunity for the CareFall program to expand in an efficient and practical format. He ensures that the provided software is current and operating to expert levels of data collection and monitoring, as well as continue to build the CareFall brand within Canadian healthcare. In today's presentation, Jim will discuss CareFall, which is an assessment tool that utilizes cutting-edge innovation technologies designed with standardized, objective test measures to scientifically predict risk levels for falls and level of cognitive and physical care needs for residents living in long-term care homes using an integrated approach. It's proactive intervention to determine risk of a fall before the fall happens. The collected data is presented in a format that is usable to the caregiving team while allowing them to upload data to secure their allowable funding. Without further ado, Jim, you can take it away and start sharing your screen.
Thank you, Casey. Just you have to give me permission, I think. Oh, there we go. And we'll share and we'll start our show. So thank you, everyone. Thank you, Casey, for the invite and the opportunity to talk about CareFall. Very timely. We're just launching our first pilots in Ontario and across Canada with our integrated approach, and I'll attempt to tell you what we're doing as we go through this. So my partner Candace and I started this about a year and a half ago, even though we'd been in seniors health for collectively over 30 years apiece, as Casey pointed out. So we recognized that there was a lot of new technology coming out and a lot that was kind of falling through the cracks or not being able to push forward into commercialization or getting into the hands of the people that could really use it. So we are looking to enhance the quality of life through the intervention of reducing falls and cognitive decline. Those two main issues in seniors living, as we'll go through the presentation, are the key elements that come up in every discussion. How do we reduce falls? How do we eliminate falls? And how do we deal with cognitive health in terms of dementia care and how they relate to falls in general? So we do know this. These are some older stats, but it's millions and billions of dollars spent on falls after they happen. The whole push towards Canadian society, Canadian healthcare, is to try to get upstream, upriver of these and provide more preventative means of medicine and care, and that's what we're looking to do here. Again, a large number of deaths occur because of falls. We can state that falls do change the trajectory of someone's health simply through the cumulative effect of damage done with cumulative falls. And obviously the caring for falls and rehospitalization is strained due to the lack of beds and beds that are deemed to be alternative levels of care. And we'll talk about that a little bit further in a couple of slides. So we want to be able to predict and reduce falls, but it's difficult because of the reduced number of human resources within healthcare. So we know that every province struggles with the numbers of staffing in facilities, and this is what we're looking to try to help augment with our tool. And we also know that even if there was great new tools like CareFall, getting them in place is difficult because of these reduced staff numbers, which is why we take on the whole assessment ourselves. So we say that we are intervention because we're going to use established and standardized objective assessments that will identify falls risks. So the keyword there is objective. Much of the falls data collected at point of admission to a long-term care facility is collected through subjective surveys. A lot of the information is useful, but quite frankly, we were the first in the world that we know of that are using biometric means to gather cognitive and gait health and put it into a usable platform. So understanding and knowing the limits gives the ability to change the living environment and care plans around an individual, as opposed to a shotgun effect of trying to do the same for everybody. And we assume that this approach, or we know that this approach will reduce falls and create environments that are safer and healthier for the individuals. So essentially, we are an objective falls risk assessment that utilizes health tech, and we will talk about the tech as we go along. The assessment is completed by our clinical team that comes to the facility or into what we will plan to do in the future, into the community, into a private residence, and is completed in 30 to 60 minutes. Now that's a broad stretch. We just finished a pilot today, and I'll talk about that in a few minutes as well. And it looks like the average assessment is more between 30 and 40 minutes at the most. Our aim is that CareFall be the benchmarking standard by which all residents of a long-term care and in other care settings, i.e. Waiting lists to go into long-term care or waiting lists for home care, that these will be the numbers used and risk levels be ascertained through CareFall. We hope that will happen. So very simply, we do our initial visit, and as I said before, the assessors will conduct that through scheduled teams with the direction of the on-site clinical teams, but we will be doing the work. We take our modalities and that collect the biometric data, and these are tests that a few years ago we wouldn't dream of being able to collect the EEG data for the cognitive health or even the gait assessment that we do. You would have to go to a clinic, you'd have to spend lots of time, dollars, and most of these would be scheduled months out in advance to get the data that we're able to collect now because of the technology. We then take those pieces of data and put them into our other platform that will be on the Interi platform, and I'll talk about that shortly. And that will allow for different care plans, again, individualized to the resident, and with the obviously intervention strategies attached to it, whether it be programming, exercise, or the like. And then they get implemented into the existing and utilizing whatever other data we're calling medicine or medications, etc., of that person. And then the key thing is we will do either, depending on either the project, the pilot, or the funding available, do follow-ups in 3, 6, or 9 months, and do another annual test at the 13-month mark. And we use 13-month as a indicator for funding years, so we can tap into funding that is annual within the senior care throughout Canada. So we check cognitive health using a technology called NeuroCatch out of Vancouver, and I'll talk about them shortly. But essentially, we are capturing their cognitive health based on their neurophysiology, and again, rather than a subjective review of behavior and self-report. So the individual, and there's a photo in a slide or two, gets fitted with a skull cap. 5 electrodes are set onto it, and they listen to a series of tones and a series of word association, and they sit quietly for 6 minutes while the software is picking up their brain activity. So again, pretty high-tech stuff that we're able to now bring to the clients. The EEG recordings, as well as recordings during the audio and visual, will actually evoke potential responses, and then the computer software captures that and creates a report such as you see there on the screen, a sample there. So obviously, again, the models are statistically analyzed against normative data, and then provides normal scores, and we're able to then analyze risk associated with the person as it pertains to falls and potential cognitive decline. Within NeuroCatch, there is the hearing auditory sensation test. So obviously, hearing is associated with a number of things that kind of gets neglected a lot of times especially within long-term care. Understanding that hearing has a balance element to it, which is obviously directly related to falling. There's a social engagement and dementia care element to hearing. As you lose hearing, you tend to detach yourself, and that causes other issues associated with your health and well-being. So obviously, we can then figure out from there what implementation we can use for them. And obviously, different socialization and hearing improvement devices can be used to avoid such problems. Our gait health is very exciting. Another application called One Step that we are the Canadian partner with. Very simple tests, series of tests that we use to record gait, stride length, balance with very high accuracy. It's all on a smartphone, and then this data is instantly compared to benchmarks to identify falls risk. So part of our overall company strategy was, again, from the beginning, the first slide was, we're going to be using established technology and bundling it, as you were, to be the project managers to deploy and implement the technology into a usable format. So the data that has been collected, and with One Step in particular, they just crossed over their 3 billionth cycle worldwide. So the data that's being collected and compared to the normatives has a very strong correlation to risk levels that they are able to spit out through their through their reporting. So obviously, same thing as the other two tests, we gather this all. And what we're using is, we're partnered with a company called Vitech Rysoft out of Finland, who are large inter-eye developers, and putting it into a menu that can be used on any inter-eye platform, and gather the data and then use their AI algorithms that are built in there and comparative data that we've collected to create the care plans. So with this objective data, the operators are able to better manage their HHR more effectively. Not only that, but we can again personalize the programs and interventions for that individual better. So having a baseline objective data will better inform caregivers the information of risk and intervenes with new and existing programs and environmental changes. So we're ensuring that the right set of healthcare professionals and caregivers are engaged instead of the kitchen sink approach, which will reduce stress on HHR and be more impactful to the residents themselves. So I just tidied my own language up there a little bit. The one thing we mentioned, alternative levels of care. This is quite a big buzzword here in Ontario, where I'm from, is trying to understand where people need to be if they're on waiting lists or still remain in hospitals. And we believe that our assessment tool can better align people with what services they would need if they need to be moved from a hospital. What level of home, what level of care can they be best suited for? And this objective data gives a much better indication of what's there instead of the objective surveys that are usually done. So I mentioned HealthTech Connects is the main company that make NeuroCatch out of Vancouver, BC. And just to give you some indication, like NeuroCatch was recognized as one of the top 15 health tech companies in a recent international MedTech conference that was in Toronto in October of 2024. They also have a large research facility in Surrey, BC, and a working clinic as well. So they are very excited about collaborating with us to get more into the seniors world to better understand and research brain health. And we are very proud and happy to be part of their team. And also, as I mentioned, the One Step program is initially out of Israel, has gone global through the US, and we are basically the Canadian partner for One Step to launch this in combination with NeuroCatch to be able to get this very powerful data into the hands of caregivers. So as I mentioned, Vitech Rysoft, we are in the process of porting data that we've been collecting and getting it in onto a platform that can be usable. Inter-Eye is used across the country and is uploaded to CAI. So the more data that we can provide CAI, the better understanding we have of the effectiveness of plans and interventions. And the term interoperability has come to the forefront again in Canadian healthcare to be able to let data talk to different portals. And we assume that we will be cutting edge when it comes to this, and we hope to keep this going as we add more and more homes to our stable. We do have some current pilot projects in differing scope of work. The first one was completed today. We did 18 residents in independent living. So these people are more or less on their own, but do have mobility issues as identified by the staff. We're then going to do a behavioral unit where people are very mobile, but do have a degree of cognitive decline. So we'll be looking at that as a specific population. Then we're going with another group, we're going to do a whole LTC home in comparison to the other homes that they have within their portfolio. And the last one's more of a case study in this particular home where the family is insistent that their loved one be restrained, even though that goes against basically LTC Act and good policy, but they are very concerned that this loved one is falling quite often. So we're going to put them through the CareFall testing and probably do it more than 3 to 6 months. We'll do it every month as they intervene with programming to see if they can improve this individual's mobility to the point where they don't need to be restrained. So that's a little interesting twist on things. So here's some photos from this morning. This is up near Ottawa, Ontario. So you can see the picture on the left there is using the one step. If they don't have a pocket to put their smartphone, we have a holster that basically holds the phone as they do a short series of exercises, and that whole process takes about 3 minutes. We do some sort of old school tech. We do grip strength as well. There's somebody in a quiet room getting strapped in with the skull cap to do the narrow catch testing. And we also do a quick eye test on the depth perception. And in this particular home, we were able to find that 2 of the individuals actually had double vision that nobody was aware of. So just by doing these simple tests, can find other things that you weren't, the staff may not have been aware of. Currently, we will produce these type of reports just on the level of risk. There's tons of data that comes out of both tests, but we try to scale it down so that's put into a usable format for the caregivers to implement. As I said, either they'll have programming in place that they could direct an individual to, or they will create new programming that a collection of people coming out of the CareFall would benefit from. Not just physio, but potential neuro training type of exercises, meditation, that sort of thing. So what we call our rallying points is, again, Candace and I being in the industry for a very long time, there's a significant shortage of healthcare human resources across all sectors, and those in caregiving are burnt out, and that makes new technology difficult to adapt. So we're saying, let us do it, and we'll give you what you need out of it. Objective testing does not happen because of the cost, time, and inconvenience for both residents and caregivers. As I alluded to earlier, these tests, even a short time ago, would be very costly to do, almost impossible to arrange and schedule. And again, when we're dealing with an older population who lives in senior living, the ability to get them to and from appointments is already staggering. So it just wouldn't happen. So we do bring the technology to the resident and complete the assessment. So again, by providing this objective predictive evidence, we will decrease the risk of falls, the number of falls, and obviously the cost of falls. I haven't really dwelled too much on that, as we saw in the early slides about how much falls cost, and many of you who would join this type of webinar will understand the overall cost. But if we can reduce that with the hope of policy being changed to, again, fund these type of assessments as opposed to throwing money after the fact, we think that we can actually save the system a significant amount of money. Last few slides here. So our pillars are really intervention. We're using that health tech to tailor care plans through objective measures. Interoperability. We want to ensure that our data is safe and transferred to usable platforms, following standardized protocols such as they are being developed currently. Alternative level of care identification. Again, I went on about that a little bit in the last few slides. And risk management. We have talked to some insurers who believe that if this is put part of a plan, that potentially premiums could be lowered to the building operators themselves. We've put together 10 advantages of CareFall, and many of them we've talked about in the last few slides. One thing we may have not have done is about mobility device assessments. Many of those across the country are done with the help of occupational therapists on an observation or trial basis. But we believe that maybe, especially the gait analysis part of this data could be used to make better predictions on what device can be used for, and longer. Obviously, we'd like to see people more mobile as long as possible, because that affects their health much to the benefit of themselves. And the rest of them, I think we covered in quite well context throughout the presentation here. So again, there's our partner ecosystem. We talked at length about NeuroCatch, One Step, and RISOFT. The Institute of Sport and Health Performance is our clinical team that goes out to do the delivery of the assessments and reporting back to us. And we do have a strategic alignment with Helping Hands Healthcare, which is trying to change the way staffing is done across the country in terms of providing the best possible and predictive staffing into long-term care in hospitals. So they're a very good partner of ours. And skinopathy, which is another technology that actually monitors and can diagnose skin wounds and skin health, basically. And they're doing quite well internationally as an app that can predict skin cancers and open ulcers, et cetera, et cetera. So very, very good partner of ours. I'll just skim through. So Candace, as I mentioned a few times, is our CEO and founder, and has numerous multinational and international age and wellness initiatives she's been behind, and has been doing this for over 30 years. And Jennifer Clodney, who will be joining us full-time in January, has ran neurovocational clinics and has owned them for well over 20 years. So she brings that neuro background to and clinical and rehab background to our team. And you heard about me from Casey at the beginning. So there we go. I'll stop sharing now, Casey.
Perfect. I want to thank everyone for joining us today for this insightful Policy Round webinar. I also want to extend a special thank you to you, Jim, for presenting your valuable findings and sharing the vision for the future of CareFall. We do have about 10 minutes or so for any questions if you want to put them below in either the chat or there is the Q&A box as well. And we'll go ahead and have Jim answer them. Jim, there is one currently in the chat. I don't know if you can see it there.
Sorry, which one? About the independent, or sorry, community clinics?
Yes.
Yeah, and that is our overall plan to actually, we're starting in long-term care so that we can gather the most data the quickest, because of obviously the populations are available to us, and it makes it easy. But we do believe, and we've heard from a number of people that getting into the community prior to long-term care, and that's that whole alternative level of care measure is can we keep people in their homes longer? And really, that's what we have to do as a society, because we just won't be able to build the amount of facilities, and nobody, I'm from the age in place world too, is I know that multiple studies over the last several years is 90+% of people would rather stay home. So that is the ultimate goal of CareFall, is to go out into the community and do these assessments as part of a routine, get that data back to the governments that fund home care, and start to shift the funding away from acute care, or at least fairly share it or enhance the home care world. I know some provinces are doing that. It's tough because of the layers that we have within Canadian home care, but indeed, that's our goal, is to get into community clinics. Here in Ontario, there's the We're looking to start to build seniors hubs built around long-term care. And we envision that clinics will be able to do this assessment as part of a routine.
Give it a couple more minutes there to see if there's any more questions that trickle in.
I do have one if I could just ask live, maybe.
Sure.
Um, just another one on the pilots piece and what you're capturing in terms of actually I'll backtrack. So whenever the assessments are completed in the pilots and you have those reports with recommendations,
Yes.
how are you tracking or are you tracking kind of what that implementation also looks like with like the staff support
Yes.
and things like that so that they know that they should do the chair, sit to stand, and integrate that into their workflow?
Yeah, I kind of skipped through that. I'm not the implementation person, but with Jennifer and Candace, they're working, like in the case of the first pilot, Candace was there. So we will work with the staff and bring the reports back to them en masse and say, what programs do you have existing? What can you implement? What improvements can you make? And then when we come back in the case of these pilots, we're going to be doing 3-month follow-ups because we want to see in a shortened time period, because we want to get to the different levels of government sooner to prove that this does work. And as we said just previously about communities, can funding be redirected to do these type of assessments for the betterment of everybody? So we will go back and do that shortened follow-up and compare. We'll be able to compare the participants' scores.
Thank you so much. This is fantastic and fantastic presentation.
Oh, thank you. Well, thank you, Casey, again for inviting me.
Yes, absolutely. I'll give it another minute or so, just in case there's any, in case that maybe sparked any more questions.
I'll just say because this is being recorded, if there's anyone listening who wants to be involved in a pilot, we'll gladly do it. These pilots are being funded through the nursing envelope here in Ontario, so there is year-end monies that are being used for that. So, but again, we've talked to people in BC and New Brunswick and some of the other those are the key provinces we have spoken to. But would want more information, want to talk, simply reach out. We talk to everybody.
Absolutely. Okay, so if that is all the questions for today, as Jim mentioned, this webinar is being recorded and it'll be up on our APTA website as well as our YouTube. So definitely keep an eye out for that. And once again, thank you everyone for attending and thank you, Jim, for joining us today.
Excellent. Thanks again. Take care.